Okay, well, it is 1:30, so out of respect for everyone's time, I think we should get started. So good afternoon, everyone. My name is Sarah Jacobs, and I am the mammography coordinator for Allina Health in Minnesota. I also work as a consultant for mammography educators. And I'd like to begin today just by mentioning that every interaction in healthcare begins with at least some form of communication. You know, whether it's a verbal introduction or a nonverbal smile or written communication out in the hallways telling us where to go, how to get here, or online education and communication. If that communication isn't effective, it fails. And if communication fails, so does trust. If there's no trust, it doesn't matter what you as the radiologist, the technologist, or even your patient is planning on communicating. In the general session yesterday, we talked a lot about trust. It was discussed extensively, and it doesn't matter if your patient is male, female, transgender, masculine, feminine, or any other term coined by cultural theorists. It doesn't matter if they're from Ethiopia or from California. If that communication fails, progress cannot be made. I am incredibly grateful to be here today to talk about something that's so easily overlooked in our day-to-day interactions, but can make such a positive impact on the level of care that we provide for our patients. Women across the globe have many differences: their language, culture, religion, environment, personality, but their similarities are undeniable. And enhancing communications and creating a focus on being intentional with our patients is something that all techs, radiologists, and medical imaging personnel should concentrate on in order to relate to their patients no matter their cultural background. Here's the thing: alleviating communication problems and building connections with patients is common sense. But unfortunately, these problems still exist and persist even in the best healthcare systems across the nation. So sometimes we just need a little reminder on how and why we need to adjust our best practices in order to avoid those interactions that send us backwards in terms of patient care. Today, I'll discuss techniques to identify common communication problems with patients across various cultures that lead to poor patient satisfaction. We'll establish how improving communication can reduce medical and communication errors while facilitating patient follow-through, and we'll establish skills for improving communication through cultural sensitivity and essential communication tips. In May of 2018, over 23,000 medical malpractice suits were reviewed from 2009 to 2013, and the study found that 30% of the cases were a direct result of miscommunication or a lack of communication, and over $1.7 billion was awarded in these suits. So is poor communication in healthcare really that much of a challenge that many have difficulty overcoming? Unfortunately, yes, it's undeniably an issue, but one that we can remedy if we focus on bridging communication with each and every patient, no matter their background. It's no secret that in any field, poor communication offers a negative impact. In healthcare, it negatively impacts our patients, the one person we're trying to support. And male radiologists, well, you certainly have a disadvantage over your female colleagues. In breast imaging, especially, patients tend to prefer female physicians. The HRSA, an agency under the U.S. Department of Health and Human Services, published a study in May of 2016. The study showed that those with gender and ethnic diversity responded differently to patient care, and patients were more likely to perceive higher quality treatment and care when they shared some of these gender and diversity traits with their physician. Female patients tended to have this perception of better communication with their female physicians. That doesn't mean that male physicians can't use the tools and tips that we'll discuss later to improve patient communication. They may just have to work a little bit harder to build that connection. We've established that a lack of effective communication in healthcare is already an issue, and as many of the communication problems that we encounter in healthcare, we know that they're fairly universal. But what happens when these problems are coupled with cultural sensitivities or other cultural barriers? Of course, it creates magnified problems. Cultural challenges that tend to be forefront in the list when treating patients from various cultural backgrounds are language barriers, which of course is probably the most common, literacy barriers, and cultural sensitivities such as personal space, customs, belief, and patient perceptions. The biggest communication problem is we do not listen to understand, we listen to reply. The gap between what is said and what we hear is linked to how slow or how fast a person speaks. And the average person speaks about 175 to 200 words per minute, but most people are capable of listening to and processing 600 to 1,000 words per minute. So because of this, our brain is not always fully focused on what someone is saying and goes off in different directions. This prevents us from understanding what is actually being said. Most of us, leadership included, have not been taught to effectively listen. And effective listening is a learned skill. It does take time and practice to perfect. So if we can't listen effectively to our patients, their families, or even our colleagues, then we're not able to learn about each other, and therefore we cannot build those effective connections that create harmony in our workplace. There can be many common communication problems in our immediate work environment, but these are a few that are the most common specifically between radiologists, technologists, and patients. Defensiveness, interrupting, having a lack of empathy, and a lack of understanding, which is probably the biggest problem. And we'll briefly discuss defensiveness first, again, because it's the most common. So when someone becomes defensive, they tend to shut out the person that they're conversing with. And this isn't limited to just patients or their families. Healthcare professionals are just as susceptible to this problem. This leads to frustration and a whole slew of other communication problems, because the defender tends to stop listening and focus on their response instead. So they're not hearing, much less understanding, what you're saying. Remember, too often we listen to reply, again, not to understand. So when patients become defensive, we've lost them, and we've opened up a whole new set of communication problems. As techs and radiologists, we subconsciously become defensive too. When patients don't understand the instructions that we give to them, when the language barrier inhibits answers to simple questions, frustration then becomes a detrimental consequence to defensiveness. And because it's fairly easy to identify frustration, seeing signs of defensiveness in our patients is probably the easiest to identify, but unfortunately, it's not so easy to remedy. Because once you've traveled down that path of frustration and defensiveness, your patient will have a more difficult time opening up and following through. You'll know when your patient is starting to become defensive by tuning into their emotional state, their body language, their sensory responses, and tone of voice or their vocal style. And we'll talk about, again, each of these briefly over the next few slides. We'll start with defensiveness in emotional state. Defensive behavior can manifest in erratic or agitated behaviors, not smiling, losing any sense of humor, or being apathetic or listless. And body language goes hand in hand with defensiveness, and this is a big one. Noticing a change in body language is especially common when we see patients come back in for diagnostic workups. You'll get the patient that comes back in showing that although she's a bit nervous, she's happy to have been called back because she'd rather be safe than sorry. You may have the patient that comes back in and they avoid eye contact at all costs. They might look annoyed, look down, or be really tense when you try to position them. And again, you have to remember that these are all signs of defensiveness. The sensory response, though, is harder to see. Patients and their families feel sensory responses such as nausea, hyperventilating, tachycardia, myalgia, anxiety. It's important for us to be in tune to these types of behaviors before they escalate. The last sign that we'll talk about is tone of voice or vocal style. And this one, of course, is easier to identify than the sensory response because we can hear tone change or volume go up or down. We can hear anger and sarcasm. I have had plenty of patients that giggle throughout their entire exam. Maybe you have too. And it's a nervous giggle, and it's everything that they can do not to turn around, run out the hall, and get away from that intimidating exam that we're about to perform on them. We are all prone as patients and as healthcare providers to these defensive mechanisms, but again, it's imperative that we recognize these behaviors immediately and adjust our responses accordingly. Interruption. You'd be surprised at how often this happens. In the healthcare setting, guess what department has interruption happening the most frequently? You guessed the ED, right? It occurs the most often during times of high anxiety. Who said ED? Did anybody think ED? Yeah? You get a prize. Just kidding, you get a free trip to the ED. There tends to be a high level of anxiety in our patients and their families when we bring them back in for breast imaging. We all know that radiologists, you have a long line of patients to get through in a day, and it's easy for you to plow through the conversation. But if your patient is anxious, they need to feel your full attention and your empathy. A study by Beckman and Frankel found that physicians interrupted their patients' initial statements 77% of the time, and the average time it took for interruption was only 18 seconds. Sad, isn't it? When interruptions occur, the patient may perceive that what they are saying is not important, and this tends to lead to the patient being hesitant to offer additional information or even ask questions. The end result when interruption happens is that your connection with patients suffers. It's difficult to bridge the disconnect, and there tends to be resentment. We tend to notice more if we are the ones being interrupted, though, versus if it's us as healthcare professionals actually interrupting someone else. So if a patient is interrupting you, you can allow your negative emotions to take over your thoughts and your reactions, or you can choose an alternative path. You can shift your thinking by asking yourself if their behavior is intentional. Did they intend to offend you? Most of the time, your answer is going to be no. It wasn't completely intentional for them to interrupt or offend you, and it was the patient's unconscious reaction to whatever you were saying or what was happening during that point of time. Pause, recognize, then respond. Don't react, because interrupting likely puts the patients in a tricky point. You know, they're reacting because of whatever is happening to them in that context of the situation. Next up, lack of empathy. Some people have a very difficult time empathizing with others, and for some, it comes naturally. It's not completely uncommon for techs and radiologists to offer empathy to patients. Thank goodness for that. But depending on the radiologist, the tech, or even the patient, it doesn't happen consistently. And it's even harder to empathize with patients when cultural sensitivities or barriers are present that affect care. We can see how detrimental this could be to communication. Having empathy toward others and their situation allows patience. It allows respect and connections. But when there's a lack of empathy, there tends to be a disconnect. We don't read between the lines. There's no practice of emotional empathy. So unsolicited probing of a sensitive topic on the opposite end, or not inquiring of emotional support when somebody wants to share something sensitive, really prevents a good relationship between provider and patient. And what our patients, especially in breast imaging, need the most is empathy. So being able to read between the lines is especially important in the healthcare setting. Most times, patients aren't going to tell us what they're thinking. Some tell us way too much, but that's another story. They might show us how they're feeling by offering cues from their body language or by the tone of their voice. When women come back in for a breast imaging procedure, there's almost always this looming fear of the result. And unfortunately, should a diagnosis such as breast cancer be that result, physicians tend to state the facts. They say what they know. And facts are important, yes, but many times this news is delivered without emotional empathy. Sensitivity to a woman's cultural background is many times ignored when you're stating the facts. The way you deliver this empathy may need to change depending on the cultural background of your patient. In order to overcome this lack of empathy, paying attention to both physical and emotional comfort is imperative. Keep the patient covered as much as possible. Address the patient respectfully, using her last name. Be professional. Be aware of our cultural sensitivities, especially physical space. Keep in mind that some cultures prefer a very short distance between two people when communicating, such as the Latin American culture. In other cultures, personal space tends to be greater, as in Middle Eastern cultures. So what does too close look like? As you can see, it depends on the global region and cultural norms. In England, individuals tend to require a lot more space than someone from, say, Latin America, where again, individuals can be very close with, or very okay with close proximity. In Romania, individuals tend to take longer to establish trust, as seen by how much distance is desired between two people that might be considered strangers. Now, likely you'll not remember how close is too close, and that's okay, but keep in mind that your patients may come from all over the world, and you just need to be sensitive of their personal space before you just jump right in. Another big problem is lack of understanding, and this goes both ways, both in terms of a lack of understanding on our end as healthcare professionals, and also with patient understanding, of course. When patients don't understand, there can be inconsistent or even no follow-up. Many times, there's a delay in care, medication errors, incomplete patient preps, there's anger, frustration, defensiveness, all which can lead to poor outcomes. But when we, as healthcare professionals, don't understand what the patient is trying to communicate to us, the outcome can be catastrophic. A lack of professional understanding leads to inadequate documentation, think informed consent. There can be unsympathetic responses, inadequate educational materials and mediums for distributing the materials, and inappropriate treatment or course of action, among many other undesirable consequences. And when the communication is inadequate, the result can mean longer wait times, poor workplace conflict and poor decision-making, unnecessary stress, and among all of these consequences, as we discussed previously, one of the biggest consequences of poor communication is medical errors. When communication problems happen with our patients, they're frustrating. And again, these frustrations are magnified when our patients or their families don't feel a connection or have a lack of understanding. If we want to address these problems, we have to understand their source and identify the source. So of course there are many sources for communication problems, but in breast imaging, when working with patients from various cultural backgrounds, these sources stand out the most. Unconscious bias, anxiety, and cultural competence. Unconscious bias is a natural, universal method of cognitive processing. Unconscious biases are social stereotypes about certain groups of people that individuals form outside their own conscious awareness, and everyone holds unconscious beliefs about various social groups. And they form our tendency to organize social worlds by categorizing. Research shows that our brains make decisions up to 10 seconds before we even realize the decision that we're making. Unfortunately, as natural as these biases are, unconscious bias can lead to false assumptions and negative outcomes, and this is especially dangerous in healthcare where decisions can mean life or death. As more attention is paid to health disparities in the United States, there is increasing evidence that unconscious bias leads to negative outcomes for minority groups in healthcare settings. For example, you see Dr. Singh's patient coming in, checking in at the front desk, and you overhear her tell the technologist with some form of sarcasm how excited she is to have her biopsy. Yeah, that doesn't happen, does it? She thinks the worst, and she is vocal about it. And you think, thank goodness she's not my next patient. And then you find out she indeed is your next patient. And you think to yourself, great, this is gonna go just great. That right there is your unconscious bias talking. Unconscious bias manifests in various forms. There's actually over 150 documented forms of unconscious bias. These forms tend to be more common, though, in the healthcare setting. Confirmation bias, or looking for ways to make an initial judgment come true. Affective heuristic bias, judgment based on superficial factors such as a person's weight or visible tattoos. Gender bias, judging a person's capabilities based on their gender. And intuition bias, that gut feeling that we get. In order to avoid allowing these unconscious biases to negatively impact our patient care, we must first be aware of them. Awareness is key to communicating effectively and conquering these unconscious biases. Be authentic and sincere. Notice your tone, because it can undermine the very best of intentions. Use non-judgmental language and avoid defensiveness. For example, say, I'm going to ask you a few questions related to your history for the purposes of updating your chart with the correct information, rather than saying, when was your last menstrual period? Or are you taking any hormonal medications? The problem with these statements is that patients tend to jump to the why. If we're not explaining why we're asking these questions, they're going to get defensive. And again, that leads to a whole nother set of problems. Check for understanding. Listen for a new understanding that might emerge from the conversation and really learn what the other person is trying to say. Anxiety. It is no secret that anxiety is high in patients coming in for breast imaging. Even screenings can cause a lot of anxiety or harm, as Dr. Miglioretti discussed yesterday in her keynote. This anxiety tends to come from past experiences, from word of mouth, incorrect or misunderstood information, lack of information, or even pressures from society or the communities that they live in regarding breast imaging. Patients may even have high anxiety about their body type, their breast shape, and about modesty. And these are all things that we tend to forget about because, well, we work in breast imaging all day, every day, but these women come in once a year, or in some cases, they come in biannually. This anxiety clouds intake. And just like when there's a lack of understanding on the patient's end, when there's anxiety, there's a good chance your patient won't be able to comprehend all that's going on around her, whether it's instructions for follow-up care or something as simple as breathing instructions during the exam. Anxiety is evident in our patients' comments, questions, and of course in their body language. And again, it's not uncommon to have a patient with magnified anxiety when we have to work around a language barrier or another culturally sensitive issue. You'll notice indicators of anxiety through the patient's inability to follow simple instructions, through avoiding eye contact, or again, that continuous laughing or giggling that we talked about before. The patient may make condescending comments. Is this all you do all day long? How many of you have heard that before? Oh, yes. Yes. All of us techs in the room, you kind of know what I'm talking about here with the condescending comments. Maybe you've given your patient some changing instructions and you've said, remove everything from the waist up and then have this gown open to the front. And you come back to get them and they're completely naked. Happens all the time. That's anxiety. Alleviating this anxiety is important. Explain to the patient what to expect before you proceed. Communicate with her throughout the entire exam and physically show her what you're going to do before you do it. Offer visual aids if needed, rather than just speaking the instructions, especially if there's that language barrier present. Use body language and speak clearly, but not too fast. Maintain a comfortable environment. Warm gowns are always a good idea, but make sure the gowns actually fit the patient. In order to alleviate this high level of anxiety with the patients of various cultural backgrounds, understand those cultural differences, because the more that you know about your patient and their culture, the more they'll trust you. Understand that the cultural differences of the patients you serve is vital to your organization's success and your patient's compliance. In many cultures, medical decisions are made by immediate or extended family. And if the family can be involved in those decisions, the patient will be more likely to comply with treatment or follow-up care. Cultural competence. The U.S. Department of Health and Human Services states that practicing cultural competence to honor diversity means understanding the core needs of your target audience and strategically designing services and materials to meet those needs. Understanding depends on the ability to perceive, react, and accept differences and similarities. The developmental model of intercultural sensitivity by Milton Bennett explains this in 6 stages. 3 of them are ethnocentric and 3 of them ethnorelative. This model demonstrates that perception is flexible and that we all have the ability to reformulate our sensitivity to various cultures. On the left, there are 3 parts to the ethnocentric stage: denial, defense, and minimalization. In these 3 stages, we have the attitude that our own culture is superior to other cultures. In the ethnorelative stage, where acceptance, adaptation, and integration are learned skills, we consciously are able to recognize behaviors and values as cultural matters rather than universal ones. For more information on this model by Milton Bennett, Penn State published a really good article in May of 2015 titled Cultural Sensitivity in the Workplace, and it's a really great resource that's easily found on Google or the internet. Going hand in hand with recognizing unconscious biases, in order to understand cultural competence, we simply need to be aware of our own cultural beliefs. So don't reinvent the wheel here. Let's find out what cultural competency programs are already offered by our organization or institution, because many times they already have educational materials in place. Being aware that of the environment that we're putting our patients in and acknowledging that privacy and modesty is key. Know what specific cultures and backgrounds your facility cares for. Know that direct eye contact is considered impolite or aggressive in some American Indian or Indo-Chinese or Arab cultures, if that's who you're serving. Know that some Hispanic patients may keep their eyes downcast as a sign of respect to others. So when your patient won't look you in the eye, perhaps it's out of respect and not just defensiveness. Finding that balance between knowing your patients and reading their body language is really, really important. Another way to be more culturally competent is to introduce yourself and explain your role. Everyone that comes in contact with that patient should be doing this, everyone. Names are great, yes, but when they can identify you with your role, they'll be much more receptive. So often there's this presumption that you and the patient are on completely different levels or different sides. Make sure that she knows the 2 of you are on the same team and that you'll be working together throughout the entire experience. If they've had a negative experience in the past with your facility or with breast imaging in general, talk about it, acknowledge their experience, apologize if necessary. Make sure that you tell them, I'm sorry that you had that experience in the past, but let me tell you how this experience is going to be different. So as the radiologist, as leadership, as someone who just wants to communicate better with patients from various cultural backgrounds, where do we begin to make a change? Here's a little tip. Start with trust. Then by making small improvements, and then always be aware of perception. The easiest way to build trust with any patient is to focus on effective communication, which requires compassion, respecting personal space, and cultural sensitivities. Recognition of your patient's emotions or avoiding and eliminating distractions is really important. That means being engaged 100% of the time and being present with that patient. Put the cell phone down, keep it out of sight, because we are increasingly bombarded with stimuli, both auditory and visual, and we can find it very difficult to focus our attention on just one source. So remember to give your patient your full attention. In order to build trust, it's a really good idea to develop scripts, to focus on that introduction and that first impression. And if the patient appears to be nervous or upset, again, acknowledge their feelings and attitude. When developing scripts, imagine how a patient might feel when she checks in at the front desk and she's greeted by her last name and is treated professionally and respectfully. And then she goes off to mammography, where the mammography tech does the same thing. She treats her respectfully, professionally, addresses her by her last name, and then she goes to another procedure where the technologist says, "Hey, Sandy." She assumes over-familiarity and has her take a seat on the table, just open her gown and say, "I'm gonna get some pictures." Imagine how that patient's perception of her experience in your facility changes dramatically with one small interaction. Handoffs are extremely important. Scripts for callbacks, scripts for schedulers, scripts for text to use when talking about screening recommendations are really important. If I would perform 20 mammograms a day on 20 different patients, at least 10 of those patients would say something like, "My doctor says I only need to have a mammogram every 2 to 3 years." Do you guys hear that often? Yes. Make sure that as radiologists and healthcare professionals, we're working together to develop scripts to appropriately address those concerns from the patients. Don't just ask her if she has questions, because 8 out of 10 times she's going to say, "No, I'm good," and then she'll leave, when she really truly does have questions. If you recap what you've already discussed and create a mutual dialogue where you're asking questions that pertain to her understanding, that will really, really benefit her or her family if they're present, and it'll increase the chances that she's actually interpreting what you're saying. After the radiologist leaves the room, and maybe technologist, you're still in there with the patient, say something along the lines of, "Okay, now that Dr. So-and-so has left, can I answer any additional questions that he may have gone over with you?" It's just one more step to making sure that the patient is truly understanding what the instructions were, and that, if there's follow-up care instructions or guidelines or anything like that. When you first meet your patients, you have 7 seconds to actually build a connection with them. During that first interaction, you as the radiologist or MAM tech, you are in the driver's seat, and you are in control of that connection, whether it's built or whether it's not. So when you first greet a new patient, approach them slowly and wait for him or her to acknowledge you. Rushing the patient may exacerbate that anxiety or that fear of the unknown. So don't be overly familiar or casual with the patient. And if there's a language barrier, be sure to use an interpreter. If you can, use a medically trained interpreter. Not to discount the patient's family by any means, because sometimes we have no choice but to use the patient's family. It's just that they can kind of translate ineffectively, or they can contribute to unconscious bias a little bit when they're interpreting. In order to acknowledge the feelings of the patients, often the best response is to listen. When they express concerns or emotions related to an event or situation, sometimes we're often reminded of our own stories, and we feel better about sharing them. Although our intent is to demonstrate understanding and show emotional support, we tend to miss the greater emotional need of the patient, that they simply need to express their feelings and be heard. We need to be sensitive to our patient's perspective, culture, and desired path to wellness, recognize their spiritual health, and we also need to be aware of gender concordance, because in some cultures, women are not permitted to see male professionals unless there aren't other options. So we need to be sensitive and aware of this. The second part of this little tip is to start by making small improvements. Work on making small improvements to adapt to cultural sensitivities. Again, we don't want to reinvent the wheel here. If you already have protocols or procedures in place that contribute to a high level of patient satisfaction, see what small improvements can be made to those already existing plans to increase the level of cultural competence for your staff. Involve the patient's family in decision-making if you can. Again, use medically trained interpreters, because it is equally important to be clear, concise, and use terminology that the patient understands, because even the most educated and aware woman is not familiar with breast imaging terminology. Miscommunication of the message or the language could be offensive to another person. So offer educational materials in the patient's native language and use illustrations if necessary. Use written, audio, or visual tools, such as brochures or videos, if you can, to help with the patient interaction. Another idea for improvement is to start with a community needs assessment, if you haven't done one recently, to determine the various patient populations that your facility serves. Use patient navigators, and again, tailor that scripting and your educational materials, as well as your attention, to cultural sensitivity to those particular patient populations that you serve. Again, if you don't have specific scripts that your techs, schedulers, and staff use, you really should. Radiologists also need to practice consistency in key words that they're using with patients, because if you have 10 radiologists, they're going to say the same thing, or they're going to say 10 different things to convey the same message to one patient. Perception can be the hardest to navigate. Understand your patient's point of view. For example, if your patient understands that she's coming back in for more pictures, and then she gets to go home, but now you're telling her that she needs a biopsy that they're setting up for in the next room, that can be really, really uncomfortable. If you're not careful, it's really difficult for her to comprehend that message. And she's all of a sudden perceiving that she's dying. So make sure you slow down and back up. Ask her what her concerns are, acknowledge them, because perception plays a huge role in compliance or non-compliance. Just one small factor can change the patient's entire experience. If you only have gowns that are one size fits all and they won't accommodate a larger woman, that patient's perception of the care that your organization provides goes completely downhill. On the opposite end of the spectrum, that patient could have had the most uncomfortable mammogram that she has ever had, coupled with fear and anxiety. But if the radiologist and the technologist did an incredible job of explaining how she's going to get the results and what to expect, she felt safe and secure, and she's going to perceive that she had amazing care in your hands, despite how horrible the mammogram may have been. Understand that your own perceptions and unconscious bias plays a role in this. A lot of the early literature on cultural competence focuses on a multicultural approach, where providers learn relevant attitudes, values, beliefs, and behaviors of certain cultural groups. From this approach, we can learn the do's and don'ts for each group. There was a focus on broad ethnic, racial, religious, and national groups, but the problem with this multicultural list of traits type of approach is, is that the culture is dynamic and it's multidimensional. And there are many variables that affect all aspects of the patient's experience. So even in the same cultural group, there could be differences in political association, in class, in religion, in ethnicity, and even, of course, in personality. So a newer approach to viewing culturally competent clinical practice focuses on foundational communication skills, awareness of culture and social issues, and health beliefs that are present in all cultures. And we can think of these as universal human beliefs, needs, and traits. This more patient-centered approach relies on identifying and negotiating different styles of communication, decision-making preferences, roles of family, sexual and gender issues, and issues of mistrust, prejudice, and racism, among so many other factors. So leadership should really focus on a more cross-cultural approach to patient-centered care. When we communicate effectively with patients from all backgrounds, our patient experience scores go up. We know this, it's no secret. Patients are more engaged and they're more likely to trust us. They're more likely to follow through with instructions and actually hear and understand what we're saying while we're educating them. Listening is maximized, and because of this, patients are more likely to ask questions and contribute to the conversation. And that's what we all want, right? We want them to leave our care with a good understanding versus having questions and making their own assumptions. So with improving cultural competence, there needs to be a huge emphasis on leadership. Diverse leadership can affect the healthcare policy of a practice or institution to be more inclusive of the population that they're serving. We all learn from one another. So leaders must inspire this action, and leadership has to set a clear vision for focusing on high-quality care with every patient, no matter their background. So when we have patients that come in from cultural backgrounds that we might be unfamiliar with, we really need to take the time to learn about that patient, their family, and what they may be sensitive to in order to provide them the care that they deserve and the outcomes that they're hopeful for. And isn't this the reason that we entered healthcare to begin with? That was quick. Thank you for your time and your attention. I just gave you an extra 20 minutes of your break. You're welcome. Does anyone have questions? You can come on up if you do.
and I'll be out there with my walker. You're never gonna get rid of me. I just like it too much. Somebody told me that. Somebody told me the other day, they go, you won't retire. And I said, oh, yeah, we're retired. Yeah, that's good. They said, oh, no. So I'm gonna sit here.
No, you stand.
No, you. Here the bus.
You stand.
I have a way.
Okay. So we what? How many? 3
Couple
minutes.
minutes, okay.
So start it off and we'll turn it over right away.
Oh, just let's start looking at cases.
But you're gonna show the case, right? Yeah. So I'll turn it over to you. You're running the show. Come on. You know who's really in charge, as usual. That was a pretty good turnout.
Yeah, actually, I was worried in Charcuterie. I thought there'd be like 500 people.
A lot of people left. A lot of people leaving. That was 1,100 people. Bound to be a few.
Yeah.
They're lost.
Hey, don't tell me you wouldn't be glad if you could.
No, I'm like,
No, I know. I like to say tomorrow. I may not, but I am doing a training in Boca tomorrow
you told me,
afternoon at
told me.
noon. So
are we coming to the 6:30?
yeah. They're
I don't know
tonight.
if you want to stay for dinner. It's gonna
They're
be,
not doing it tonight.
No,
Oh,
yeah.
for dinner tonight. Yeah, I think I'm gonna pass. It'll be kind of
it's
late.
gonna be too late. Yeah, I know.
Okay.
I didn't even want to do one except there were a couple of people I really wanted to see.
I know.
So I thought, it's okay.
You're so sweet. Take all those stragglers.
Come on. Mr. Joe, I think you did a good job. So we've got 1 minute. Anybody
I
know?
look. I got 4 minutes. Where's the timer on there? Is there any timer? Oh,
That's your timer.
I need my glasses.
That's your timer.
I'll get my phone.
Okay. I love it. That's interesting. We're good.
As long as I, you know what? I'm so
I feel like.
yeah, I know. I
Should we start?
Here, let me check the time.
It's time. It says 2:45.
Oh, for
Oh, wait. Okay.